Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A 70-year-old man is scheduled to undergo hemicolectomy to resect a stage 1 colon carcinoma. He developed mild angina 6 months ago, at which time coronary angiography revealed a 70% stenosis in the right coronary artery. No revascularization was performed. Medical management with aspirin, atenolol, atorvastatin, and lisinopril was initiated. He can now walk 5 city blocks and no longer experiences angina. What should be done prior to surgery to reduce his risk of cardiac complications? A. No changes to management. B. Refer for percutaneous coronary intervention. C. Start isosorbide dinitrate. D. Refer for coronary artery bypass graft surgery. And E. Discontinue atorvastatin. And the answer is no changes in management. That is A. This question asks about strategies to prevent perioperative cardiac complications in patients with coronary artery disease. Coronary revascularization has not been shown to reduce this risk. Nitrates are effective antianginals but have no specific role for perioperative cardiac risk reduction and are not indicated in this asymptomatic patient. Statins may reduce risk and should not be stopped prior to surgery. This patient is already using a beta blocker, which may also reduce risk, so no change in management is needed. Reducing cardiac risk, coronary revascularization. Randomized trials failed to demonstrate reductions in mortality or myocardial infarction rates when patients underwent prophylactic coronary revascularization prior to vascular surgery. Thus, the indications for coronary artery revascularization with either bypass surgery or percutaneous intervention before non-cardiac surgery are the same as for non-surgical patients. Patients with stable coronary artery disease should not routinely receive coronary revascularization prior to non-cardiac surgery. Conversely, patients with independent indications for coronary revascularization should generally undergo this procedure prior to elective surgery. Patients with recently implanted coronary artery stents require dual antiplatelet therapy with aspirin and thienopyridine such as clopidogrel to prevent stent thrombosis, which leads to acute myocardial infarction. Major surgery, however, often requires temporary suspension of antiplatelet therapy due to the risk of hemorrhage. Elective surgery should be delayed after stent placement until dual antiplatelet therapy can be safely suspended. Coronary stents should not be electively implanted in patients who will require major surgery where antiplatelet therapy will be withheld during the period of highest risk for stent thrombosis. If a patient anticipating major surgery develops an acute indication for percutaneous coronary intervention, consideration should be given to performing angioplasty without stenting or placement of a bare metal stent instead of a drug-eluting stent. Recommended delay for coronary intervention before stopping antiplatelet therapy for surgery. For angioplasty without stent, it's about 4 weeks. Bare metal stent, 4 to 6 weeks. And drug-eluting stent, at least 6 months. Medical therapy randomized trials have shown that prophylactic use of beta blocking drugs can prevent perioperative myocardial infarction. However, overly aggressive beta adrenergic blockade has been shown to increase postoperative mortality by inducing hypotension. Patients already using a beta blocker to treat hypertension, coronary artery disease, or arrhythmias should continue the medication perioperatively. Prophylactic initiation of a beta blocker may be useful in patients with multiple revised cardiac risk index predictors, particularly if ischemic potential is present. Patients at low risk for cardiac complications should not receive prophylactic beta blockade. If started, the dose should be carefully titrated to control heart rate while avoiding hypotension. Beta blockers should not be started at high initial doses or on the day of surgery. Statins or HMG-CoA reductase inhibitors have also reduced perioperative cardiac complications in randomized trials. Patients already using statins should continue these agents at the time of surgery. Initiation of statins can also be considered in patients undergoing vascular surgery and other patients deemed to be at high risk for cardiac complications, regardless of lipid levels. Preoperative initiation of other cardiovascular medications with the goal of preventing cardiac complications in the absence of other indications is not recommended. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who's professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.